Radical treatment. But if the patient with quiescent stone is of the other type, with a large stone in a suppurating kidney, while he may go for years without grave symptoms, he is, nevertheless, in a state of unstable equilibrium, carrying about within him a septic focus, the source of probable infection to the other kidney, and a deteriorating influence upon his whole economy. He may at any time fall a victim to an acute renal infection or to a general septicemia. And, like the patient with a smoldering appendix, he should be urged to operation. The operation of choice is nephrectomy if the opposite kidney can support life. If both kidneys are full of calculi, bilateral simultaneous nephrotomy is the operation of choice. The kidney with the better function should be operated upon first. By the same token, the only reason for hesitating to remove a stone from a solitary kidney is the fact that the function of this kidney is too impaired to withstand operation. The treatment of calculus pyelonephritis. Renal suppuration due to stone is only 1 degree less benign in appearance and less malignant in reality than anuria. Suppuration caused by calculus cannot be overcome by any medical or hygienic treatment. Unless the stone can be passed off spontaneously, an outcome to the last degree improbable in suppurating cases, its growth is fostered by secondary phosphatic deposit, while the irritation it provokes in turn feeds the renal suppuration. The stone must be removed. Pyelonephrosis and perinephritic abscess, whether calculus or not, require radical surgery. Methods of radical treatment. The radical treatment of renal and ureteral calculus consists of 3 operative procedures: nephrolithotomy, nephrotomy, and nephrectomy. Nephrolithotomy, pyelolithotomy, or ureterolithotomy is incision of the kidney, pelvis, or ureter for the purpose of extracting a stone. The term has been restricted to operations performed upon the aseptic kidney to distinguish them from nephrotomy performed upon the suppurating kidney. This distinction is valuable from a surgical point of view. The term nephrolithotomy, therefore, will be employed to designate extraction of a stone from a non-suppurating kidney, while nephrotomy in this connection will imply lithotomy of a suppurating organ. Indication for operation. The general indication for operation is the presence of a stone too large to pass down the ureter. If the calculus is too large to pass of itself, it must be removed by the surgeon. In the preceding paragraphs, the modifying circumstances have been discussed. The delusive nature of the calm succeeding a renal colic, the imperative necessity for operation during anuria, the futility of delay when the kidney is suppurating. The mortality from nephrolithotomy, pyelolithotomy, and ureterolithotomy does not run above 2 to 4%. Such a prospect, with its assurance of future safety, its lack of present danger, and its unimportant discomforts, outweighs a single renal colic, and is not for a moment to be compared with the progressive unsafety and discomfort to which a patient subjects himself by refusing operation. The advantage of early operation before the kidney becomes infected is still further enforced by the relative mortality of nephrolithotomy, nephrotomy, and nephrectomy. Nephrolithotomy, the removal of a stone from an uninflamed kidney or ureter, has, as remarked above, a mortality of 2 to 4%. Nephrotomy, the incision of a septic kidney, has a mortality of 20% to 25%. While the mortality of nephrectomy in like conditions runs from 30% upward. Add to this the mortality of nephrotomy for calculus anuria, 50%, and the conclusion is obvious that the patient who refuses surgical relief while the kidney is yet uninflamed spurns a comparatively safe and sure cure and subjects himself to a disease which, apart from its other dangers and discomforts, may at any moment bring him to a critical condition of renal obstruction or suppuration, from which he can only escape by submitting to an operation many times more dangerous and distressing than the one he seeks to avoid. Furthermore, the longer operation is deferred, the greater prospect is there of irreparable damage to the kidney, and also the persistence of stricture or obstruction in pelvis or ureter calculated to cause prompt relapse of stone and persistence of fistula.